Okay, so hello guys. It's good to see you here. The ones who are here in person, the ones who are online.
Yes, thanks for coming.
Thanks for coming. Thank you, Dr. Massa, for being here today with us
My pleasure.
to talk about something that's very special for me and for you also because we like surgeries. So it's a very exciting topic to talk about.
We do a lot of surgeries.
We do, yeah. We have a lot of surgeries here at the hospital, emergency surgeries, and the topics that we're going to talk about today I think all of them are related to emergency surgeries. Yeah,
Hmm.
I mean we won't talk about spay or neutral.
No,
Yeah,
but it's something that I think any regular vet could be able to do
yeah,
as long as they
for
have
sure.
practice and
Yes,
confidence.
yes. Or if you are not thinking to perform the surgery, you can. It's important for you to know how the patient is and how you're going to see the patient with this pathology that you
Yeah.
need to correct doing a surgery. So, I mean, it's important to know how to refer this patient or
Hmm.
how to understand the symptoms so you can see that there is something wrong with that animal. Yeah. So, I mean, there are some topics that we're going to talk about. So, wound repair, esophagostomy, DDV, that we have a lot. I think that's very common to see DDV. Big dogs, old dogs. So, we're going to talk about them and splenectomy that we can perform splenectomy when we are correcting a DDV. However, there are some other reasons that can make us to perform a splenectomy, and we're going to talk about it. Okay? So, if anybody has any kind of question during the lecture, feel free to ask us. We'll be more than happy to answer you. So, Dr. Massa, would you like to start talking about the types of wound healing, maybe?
Sure. So definitely, especially in emergency medicine, I feel like we see a lot of wound repairs,
We
and
do, yeah, for sure. We do.
it can definitely be as simple as, a dog bite, a dog ran into something stupid and now it has a laceration, anything like that. But definitely some of the big things for sure is really understanding what exactly you're going to have to do and if there's any complications that arise. And a lot of that is kind of what we end up seeing. So, the biggest thing, especially when thinking about types of wound healing, so we have our first intention, which if we're all aware, basically that's just kind of the regular closure. So this is something that happens within 24 hours of whatever's going on. So that could be like a surgical incision, that could be like a dog bite or a laceration. If they can come in within 24 hours, really we can get that kind of cleaned up, fix everything out, make sure there's no signs of any infection.
When you talk about dog bites, you sometimes you can consider not to close it completely because of the maybe the contamination, the infection, or if it is within the 24 hours, you always close it. Or I mean, because I
Depending
think that there are
on,
some concerns about it depending on.
yeah, so it kind of depends on like the size of it, how the dog is doing. So if you can close it within 24 hours, and if the dog is a good surgical candidate or a cat, then that would be ideal. It'd be a lot easier for them to keep it clean. It saves the clients money instead of having to do a bunch of bandage changes and things like that. But,
Yeah.
that's kind of the most important part of first
Yeah.
intention. But then we kind of get to second and third intention. So, second intention is more like leaving it open. So, if there is a large wound, I've seen we have this one up here, which I was able to get closed, but
This is a big one.
yeah, it
Yeah,
was
yeah, it
the
is.
dog actually ran into a trailer hitch. Um,
My one.
but if that skin wasn't there and I didn't have anything to close it with, then that would kind of be almost like a second intention or potentially a third intention because I would basically just have this open wound and I have to let it heal on its own. And with that, you can
It will take a
definitely do
long
like,
time to. I mean, if you left that open
yeah,
until the complete healing, and when you
yes,
talk about the clients, we need to talk with the clients when you have open wounds being treated because they can take a long time to complete close, and the client needs to know this because they're going to have to go to the hospital a lot of times, and they're going to
yes,
when they are at home, they're going to know how to change the bandage and how to take care of that. And not all the clients are used to this. Some people that
mm,
they don't like to see open wounds, or
yeah,
blood or things like that. They're not comfortable with this.
Yeah, it's
No, yeah,
definitely a big owner compliance thing.
yeah,
It's also, it can be expensive, so you definitely have to make sure they're aware of
and the
it.
costs, yeah, of course.
Yes, because if they're
Jesus.
coming for bandage changes every day, every other day, sometimes you have to sedate them almost every time. This
It's
is definitely
expensive.
a lot.
Imagine
Um,
sedation, the cleaning of the wound, a new bandage, 2 or 3 times a week, doing this for
yes,
months. I
yeah.
mean,
So that could be, definitely a couple hundred to a couple thousand, depending
yeah,
on how bad it is.
yes,
But
yes,
at least with second intention, we can kind of get it to heal on its own. And sometimes that can progress almost to like a third intention, which is basically where we give it a little bit of time to heal. We get rid of as much of the infection, start treating the infection. If we can, we could do bandages and things like that, and then try and close it. So if we could do it before the granulation tissue forms, that would be kind of the ideal part because then we can kind of get everything together. But that granulation tissue is when it starts to get all of that healthy stuff back.
yeah,
And then once we kind of have that sitting there, it's a lot harder because then sometimes we have to debride some of that down to get it to go back together. But usually, if we can get all of that closed, a lot of times it can do well. So these are kind of examples of the first intention where I was able to get it done
yeah.
basically within a day. I do have, so we have the Penrose drains in both of these, as you can see. That's a great way to kind of reduce some dead space.
And seroma that we are going to have
No
draining
abscesses.
from, yeah.
There's also, I have in the corner what's called the JP drain or Jackson Pratt drain. That has the suction bulb. Yeah. So,
this is a kind of active drain.
Yeah, so
Yes.
you can have basically that fenestrated end in the wound, and then that'll help suck all that stuff out. More, yeah, like the Penrose drain is passive.
Yeah.
Just letting it kind of
Yes.
fall out.
There is no way
active.
to get a syringe and drain from it. Yeah, you need to wait for the fluids to come from the drain.
Yes.
That one's different. You can use some to. Okay.
And that's also perfect for, especially if we're concerned for like abscesses or if there's a lot of bleeding. Or, I mean, I've even used it in like patients where we have like thoracotomy or, anything like that. So, but moving on to kind of the more extensive things like second and third intention, where we basically have to give it a chance for it to heal on its own. We do have to do sometimes bandages. So if it's like an arm thing, sometimes you have to do a whole bandage. You can't just do a tie over. And it's a lot easier, I feel like, to do a whole bandage sometimes because it's
maybe it's
easy
faster.
to change.
Yeah. Because you don't
Yeah.
have to do the sutures and place the tie over.
But we do, in certain cases, if it's like on the body wall or, somewhere where it's a larger area, tie over bandages kind of work pretty well. And the way we kind of do that is more placing sutures all around it, packing it with gauze. You could either do like a compressive bandage, which is like regular gauze, or telfa pads, and you can put honey on that, antibiotic ointment. Sometimes I've heard of people doing like hypertonic saline, to kind of pull some of that stuff out, keep it protected, and then you just cover that and then use almost like umbilical tape. I've also seen
tie gauze,
stretch gauze, used as a way to tie that down and basically keep it together and keep it.
And do a kind of a pressure.
Yes.
On the on the wound.
And that can kind of help bring all of that good, healthy stuff together. And then if we change that, now if it's extremely gross, lots of purulent discharge or anything like that, sometimes we have to change that very frequently. I've done it as often as a couple of times a day, and then sometimes
more than one
time
a day.
Sometimes,
it depends on the volume of, seroma or you need to change it more than one time a day.
If it's like super gross, if like all of it kind of forms, you want to get all of that tissue out because the more you let it sit, the more likely it's just going to get infected.
Yeah.
But as this heals, sometimes it does really well for just every few days. I've done it sometimes every like 2 or 3 days, which kind of saves the owners a little bit of money.
Makes it easier to
Yeah, we can definitely, like I said, use this to protect the area. But again, cost is kind of the big thing, and owner compliance. So we have to keep a cone on. The owners can't, let the dog lick at it or anything like that. They have to actually come back. They have to give the medications. So if it's an owner that you don't think this is going to be able to work with, you definitely need to explain to them the risks and benefits of it.
Yeah.
I did put 2 QR codes if you wanted to see. It was more just for like basic wound care, open wound care, articles that I found, articles that I got actually in school as well from some of the teachers for, things to look for, just tips and tricks. Good.
Yeah.
So this was a
Some cases
patient
now, yeah.
that came to me actually for drain removal. It was 5 days post. Owner did not realize.
Made the owner get into the hospital. I just need to remove this drain.
Yeah,
Everything's okay.
I was like, well, luckily for you, it's removed itself.
You don't have to remove it.
Yeah.
That's the good news.
No charge for the drain.
No charge.
Yeah. But as you can see, it's definitely disgusting. So there's a lot of purulent discharge, a lot of necrosis.
Yeah.
So what I basically explained is we have to go back in and completely debride that whole area. I think before it was a dog fight, so it was some deeper wounds, but then when we had to do it, it actually kind of formed almost like a crater because all of that tissue was so infected. So we had to really irrigate the whole area, debride everything. And I was able to close kind of the dorsal and the ventral part of it, but that middle was just too deep. I could not bring it together. So that's when we elected to do a tie-over bandage. So as you can see, I placed the sutures all around, and we ended up basically having to put this bandage on sometimes. It's another thing I've seen used before. This was, I would say, probably a couple of weeks later. It definitely took some time. I believe she was coming to for at least a couple of months doing this every other day, every couple of days.
And the owners were okay with the costs and everything?
Yeah.
I mean,
we kind of worked it out with them a little bit. So, we didn't necessarily always need to do sedation or anything because we already had those things in the sutures.
Yeah, of course.
If they started falling out or, as it started closing more, we had to do a little bit more kind of debriding to get it together.
The good part of tie-over is that after you do the sutures, you can use them like a hook, so to pass, to accommodate the bandage over the wound. So I think the first time is the one that you have more work to do, but after that, the changes, they are easier.
Yeah, and you don't have to sedate them every time, as long as they're good patients.
Yeah.
I can't promise for like all the huskies and stuff.
For sure.
But so this was after months, basically. I don't have a completely finished product, but this was kind of what it was like. She was also a very chunky dog, so one half of her had a very large butt pad, and then this half is now completely contracted in.
Was that?
Yeah.
Oh, I
you know
remember
that?
her. Yeah,
Yeah.
she was at our last place. She did. She had a flat side and a
Yeah.
chunky side.
Yeah.
It was it definitely took a long time, but
It did.
we were able to get it done, and she did great. She was so fantastic for it.
Yeah,
And luckily the owners were good.
Yeah.
Now, this is something that I've used before. So we also have K-lasering, which helps with inflammation, kind of helps to promote healing.
This is a kind of a laser therapy.
Yes, so this one is like a cold laser therapy. The big thing with this one is that if you are placing bandages and they have like honey or other things on them, you have to be really careful because it is more like a heated laser. So you don't want to burn the honey onto
Yes, for sure.
Now that's kind of the problem, but as long as you can debride everything, flush everything off, you can use it. And we've done this as often as every 8 hours, and I've also done it, every couple of days. It's been really helpful, and it also, you can use it for other things. I've used it for like incisions, I've used it for like back pain, urinary cats, stuff like that. But at our last place, we actually started using Phobia, which is something else. I did include a QR code which has a scientific paper that explains how it works. But basically, it uses kind of this gel that you mix together, and then you slather it on the wound, and you use this light. And the light's supposed to help promote healing. It's also supposed to help with kind of like antibacterial. And with it, we were able to basically take this dog who had an amputation, which didn't go well. We had to.
What was the reason
Redebride
for the
everything.
amputation? Do you remember?
He
Why
it
was
was
he
a dog
amputated?
attack. Because the owner, that was the pepper spray one. He sprayed pepper spray all over the dogs. The dog attack, and I think we did 3 debridements, 4
Yeah, so-
debridements.
Mhm.
And
But he
then-
was. Do you know the reason that he was amputated?
Because
Oh,
the leg was just so
it
bad.
was gone.
So
Yeah.
was a kind of
He
a
was
source
a
of
small
infection.
dog attacked
maybe?
by a over 70-pound dog.
Yeah.
Like
So probably this happened because of the contamination and
Yes.
the
Well,
level
and
of the
it
infection.
was such a large area. So not
Mhm.
only did we have the leg that we had to amputate, but all of that was also bite wounds and infected tissue. So
yeah.
we had some of that healing, but the rest of it, the skin was just too tight. It just wasn't able to close. So we did do the tie over bandage, but we also used phobia. And
Mhm.
with multiple treatments,
What was the frequency of use of phobia?
I believe it's once every 5 days.
Yes, but after
about.
like 3 treatments, there was a lot of improvement.
Yeah.
It
And
took-
how long time do you keep?
It was a couple months for
Oh.
each debridement, and
No.
then
No, when
for
you
the
use
phobia?
phobia, yes. I mean, how long
you
time do you need to?
slather it? It's very quick. So the light itself will do it. So you turn on the light, and then it'll like beep or
Oh, so
something
the
happens,
equipment
and
let
then
you know when's the time to
Mhm.
Yeah.
remove it from the wound.
It's like minutes. So
Okay.
you clean it all up. If you need to debride or anything like that, just make sure it's all clean. Do the phobia, clean all of that off, and then you can do your tie over bandage again. And this is, I mean, compared to the other dog who was just a tie over bandage, which took months, this one took weeks. So unfortunately, I don't have a completely finished product, but between this was, I would say, maybe 2 weeks.
it healed amazing.
Yeah.
He was
And-
great.
Do you remember this one also?
Yeah, his name's Toby. I can remember. I
Yeah.
saw him like twice a week for forever.
Yeah.
Yeah.
He just kept coming for the
And-
phobia treatments, tie over bandages, and he did fantastic.
And the owner concerns about money was
They were good. They
And
were
I
good.
think they were
elder.
maybe also getting support from the owners.
Oh yeah,
His
from
dog
the
was-
dog that had attacked him. I think they were getting some financial support.
Yeah.
But yeah, no. The only issue with his tie over bandage is the hopping would make it come loose.
Yeah. So we had to kind of work with the tie over bandage, which is why it was helpful that we had the phobia because it's not something that he had to have for months on end.
Okay.
But he did really well. And I mean, also, especially with his prepuce and penis being right there, we had to make sure he didn't pee all over it, which he was very good at trying. But again, it healed very well, very quickly. So these are kind of the biggest things. But a lot of this, even if you don't have phobia, even if you don't have a K laser, tie over bandages, compressive bandages, any of these other things are definitely something that's, I'd say, fairly easy
Yeah.
to do.
yeah, and tie over there really useful in these difficult areas
Yes.
when you're not able to do a compressive bandage. Yeah.
And even if you can get it to a point where you can finally close it, I think that, at least it gives you a little bit more time instead of just leaving
Yeah.
it open to be infected or anything like that.
Yeah, I will. I have used the tie over in some cases. They work very well. Questions about wood healing? No.
And, you guys, what you can say about the use of honey in those cicatrization process?
I don't know about you as much, but I personally love honey. Especially, it has to be the medical grade honey. You can't just go to
Manuka.
Walmart, pick up whatever honey's
Oh.
on the street. It has to be,
Depending on the country you live.
yeah. At least here,
Yeah.
Manuka honey. I also had in, I think it was this one. I've
Mad
seen
honey.
these. They actually use these
Oh,
in
this is-
humans.
Hydrogel.
Yeah, it's like basically a patch that's soaked
Yeah.
in Manuka honey. So instead of having to like slather it on yourself, you can definitely use that instead. But I've done honey, and I like that better, honestly, than some of the antibiotic ointments and some of like the wound balms, hypertonic saline, because it's also antibiotic or antimicrobial effects. It has, all that sugar that helps promote granulation, and I think it's a good way to kind of keep it secure, I guess, moist and promote healing in the area.
Yes, because to have the healing process, the wound cannot be dry. So I mean, the honey helps to keep it with the humidity to have the healing process. So
And it's also exfoliative too. So the big
Yeah.
thing with bandages is that we don't want a lot of that just dead stuff on the top to just sit there. So as you're removing it and as you're cleaning it off, that kind of pulls some of that away because it's it's like crystallish and
Yeah.
thick. So you have to kind of get all of that off. So it's a good way to kind of get new cells being brought to the tissue that you're trying to heal.
Yeah.
I don't know about you.
Yeah, I mean, I don't have a lot of experience with honey, but I mean, basically the idea is to keep the wounds, avoid the wounds to keep dry. So I mean, you can have a good environment to do the healing process to happen. I don't know if we compare it with other kinds of products. I don't know if there is any kind of paper that tells us which would be the best one or the faster
Yeah, I
one,
know.
because I think that when we talk about wounds, the main concern would be the time frame to have it completely closed. This is the main goal that we have. And remember that if you have infection on that location, the infection is the one of the main reasons to bring problems to the healing process. So I mean, the wound will not heal if there is infection in that location. The granulating tissue will happen if you were able to win the infection. So basically, you need to take care of this.
What else have you used for your bandages?
Sulfa. I don't know what's the name here.
Oh,
Oh,
Sulfa.
silver sulfadiazine.
Sulfadiazine, and depends on the because I mean you need to know in which part of the healing process you are to know what you need to use. For example, you don't want to lose a tissue that is already healthy. But when you have that kind of tissue with necrosis, you need to remove all of that. However, when you have that other kinds, for example, in this image here, I don't want to remove this tissue anymore.
Yeah.
No.
So there are some kinds of products that they will do this kinds of removal of the tissue. So you need to avoid these ones in this
Yeah.
part of the healing process. However, when you have the necrotic areas, you need to remove that. Otherwise, it will not heal.
It's very like exudative, and you don't want that to
Yeah.
just sit there. You need it.
Yes. So I mean, when you talk about the wounds, there are different things that you need to use depending on the moment of the healing that it is. But definitely honey is an option. Sulfur is another option. There are some papers that they talk about using anything that does not have any kind of contamination and will keep the wounds wet, because the wound needs to get wet, not dry.
So saline would be a good option
Yeah.
too.
I've just done
Gel,
saline and like a
Use
wet
gel.
to dry.
Yeah. I mean, any kind of gel you can
Like
use.
sterile lube.
Yes, if it is sterile with no contamination, can use it, because
Amazing.
basically on that moment you just need to guarantee.
That is not
It
the
stays
bandage isn't going to
moist.
stick and rip off
Yeah.
healthy
Exactly.
flesh.
Yeah, because especially with wet to dry bandages, which is also good for like exudative wounds where there's
Yeah.
a lot of gross stuff you're trying to get off. You need that kind of moist layer, which saline works just as well, especially if you don't want to use a bunch of product that's
Yeah.
pretty expensive. But then you could use dry gauze on top of that, and that just kind of helps kind of pull that moisture out and pull a lot of that stuff off. And then especially when you take that off, it basically like pulls all that gross stuff off. It helps with it.
Yeah. Questions?
Okay. Esophagostomy tubes.
Yeah, I always remember about. I mean, we use these cats, not that much on dogs. I don't know if because of the size of the head, because you guys are going to, when we talk about how you place a esophagostomy tube, if you have a big dog, it's kind of difficult because of the distance from the mouth to the cervical area.
Yeah.
However, I mean, I'm much more used to use this in cats. I don't know about you.
Yeah, I've definitely, cats, especially hepatic lipidosis. I have seen it in like older cats. Owners can't quite let go. Cat's not really eating very well. Sometimes they've done that. I've also seen it with oral trauma, mostly in small dogs, like you were saying.
Yeah.
If we have like a broken jaw or something, and if there's a lot of damage here, or I've seen it in like tongue lacerations, oral ulcerations, anything like that.
Yes.
You can use that as a way to give them supplemental nutrition. But you're right, I don't really
Yeah.
see it very commonly in larger dogs.
Yeah, because it's difficult to place
Yeah.
the tube. I was just use this also after some surgeries that you need to guarantee that the patient will be able to eat. However, as they're going to do a big surgery, for example, you think that you have some doubts if the after the surgery they will be able to eat by themselves. So you place the tube. For example, if you're doing a foreign body in a cat, there are multiple enterotomies, and you think, hey, I'm not sure if this cat will be able to eat because maybe they will be in pain, so they will not eat. So when I close the abdomen, I turn the cat, place the tube just to guarantee that I have a way to feed that cat, you know.
Yeah.
Because the difficult things about feeding cats is that they can get stressed
Hmm.
when you try to get a syringe and force the foods against the
Yes.
cat.
Yeah.
So I mean,
And,
try to avoid this and place a tube
and I
always that you
mean,
can.
nasogastric tubes are a great option, but especially in cats,
The
it's a
size
very
of it,
small
yeah.
amount. So really, you only get a liquid diet. Anything else, even if you blend it down, can sometimes clog the tube. So it's a lot harder versus an esophageal tube. You can give them a lot more nutrition in
Yeah,
a larger
the
volume.
volume, yes, yes, and I mean, if you have a nasogastric, as you told, just liquids and in a very small quantity that you're going to be able
Mhm.
to
It's
put
very
it.
easy to make them vomit with those.
Yeah.
Yeah,
I
it
mean,
is.
and especially like Royal Canin has some of those liquid diets, so it does work for nasogastric and nasoesophageal tubes. But if this is something that's especially going to be more prolonged, like you're saying, a lot of healing time, patients that we need to eat right away, especially if they're having other issues, an esophageal tube works just as well. And honestly, it takes, I mean, maybe like 10 minutes, 15 minutes to place.
Yes, yes, it's a very
So-
fast procedure.
A lot easier to do. And I feel like a lot less trauma because, especially with nasogastric tubes, I always hit the terminates. So
Yeah,
bleeding, I don't want to
yeah, and I mean, you can keep the esophagus too for a longer period.
Mm-hmm.
Sometimes 1 month, 2 months, or even 3 months.
Yeah, I
The
read a
same
paper
patient.
that they actually said they've had it years.
Years.
Yeah, I wouldn't have done it. I would have said
My
maybe
God.
a couple of months, but
Yeah.
you know, end of life care that turned
Yeah.
into more than end of life. Maybe.
Yeah. I think that the patient that I placed the esophagus tube that was with it for the longer time, maybe a month and a half, 6 weeks, 7 weeks. It was a
Yeah.
cat.
Yeah, I think I've seen like 2 to 3 months, maybe if necessary, but definitely a lot better than nasogastric tubes, which are like 3 to 5 days max. And it's not really
Yeah.
something that I usually send home for a nasogastric tube because I feel like there's a lot of complications for owners. You know, it's possible it could get clogged, and then if there's any problems, or if the animal accidentally pulls it out, or anything like that, or you know, if they pull it out and they start bleeding, owners are freaking out. Yes,
They
these
are.
are definitely issues with esophagostomy tubes as well, but I
Yes.
think
And you
there's a
can you
lot of
can
it.
teach the owner how to use
Yeah.
this. It's really easy. I mean, they
Another
can
owner
handle this at
compliance
home.
thing.
Yeah, I don't know. Do you remember if this paper they talk about what was the kind of material of the tube? Because remember when we talked the other day
Yeah,
about the Foley or the red rubber or a specific one for esophagostomy? Because I think it depends.
yeah.
If you have the proper material, I think that you can use it for a longer time. However, if you do not have, I mean, you are using another kind of material to place in the esophagus, you need to consider
Yeah, I
how
think
long
it
time.
was definitely one of the like true esophagostomy tubes, and you have to really make sure. So a lot of times they'll do like antibiotic ointment and like bandage dressing changes frequently enough to make sure that the area doesn't get gross.
Yeah,
But I definitely think that's kind of one of the outliers. I don't think I've ever seen any other ones do it for years. So
yeah,
but you
Me
know,
neither.
definitely it kind of depends. I have seen red rubber tubing, and like you said, you've done the Foley
Foley,
catheters, so you don't have to have like the specific Mila esophagostomy tube if you don't have it available or you can't get it available. But red rubbers and things like that work pretty well, and you can always just still measure the exact same way.
Yeah, When you have the proper esophagus tube, they have the measures
Mhm.
on it, so it's really easy to see how long of the tube you're going to let inside the esophagus. It's easier than using the Foley.
Or you could just use, measure it with your eyes and Sharpie it, sort of thing. Which
Yeah.
is,
Yeah.
mm,
In Brazil,
better.
we used to use the Foley a lot because of costs. It was cheaper using the Foley than having the proper esophagus tube. And we do have some papers that they talk about the Foley. So I mean, we had a kind of a protection because it was in the literature to use it. So I mean, despite the fact that it was not the best thing to do, we could do. So
As long as you don't inflate the Foley.
yeah,
Because we don't want to cause any like strictures in the esophagus or anything like that. I mean, it's nice to keep it to stay, but that's just going to cause a lot more problems.
Yes,
so.
yes, we didn't use the balloon move. Yeah.
The biggest
So-
thing I would say for esophagostomy tubes, though, is definitely making sure that the patient's actually viable for it. So, if you have a cat with like a platelet count of 2, I would not go stabbing into the neck, especially when we have jugular veins, carotid arteries, all in that area.
I will
even
tell
if
you something when we show the picture of the procedure.
Even
have a
if we
good
do
story
it
with
regularly, I
placement.
feel like sometimes it's still a problem. I have also seen where it's been accidentally nicked a jugular vein before, and it turns into like a whole bloody mess. So you don't want to do that with clotting issues.
Yeah. The jugular, you don't have, I mean, blood pressure because it's a vein, but the carotid, you have a big blood pressure. One time that I was placing esophagus, I cut the carotid.
Oh my god.
The cat is alive. I mean,
Oh,
so everything's okay. But I mean, yes, it was necessary for me to do a suture and close it definitely that carotid.
Yeah.
The other side compensates the less volume of blood that is going to the head.
Yeah.
But I mean,
Terrifying.
yeah, terrifying. Because when if you get the jugular, which is not good, of course, but you don't have that blood pressure. In the
Mhm.
carotid, you have the blood pressure. So
Yeah.
I mean, there's a lot of blood.
Yeah.
Yes. After that, the cat received a blood transfusion
No.
because of the amount of blood that was lost. Yeah.
I'm sure the adrenaline was really going for you too.
Yeah. It was a good experience. Good story to tell.
Yeah.
And I was telling this.
Maybe not a great experience for the cat. But...
Yeah, but I mean, he did well. So I mean, everything was okay. The owner was complaining, but I mean,
yeah.
it is what it is. It's part of being a doctor. Yes.
So
Mistakes can happen. And you know what? It was not this cat. This is a cat that I placed this tube. This is the Foley one. But I mean, this carotid is good. So and the jugular the same. Yeah.
that cat did okay.
Yes, we didn't have the accident with this one. However, when you're talking about surgeries, it's very easy to tell the success that having surgery. However, talking about the bad part of the surgeries, the ones that are not the way that we were thinking that it
Yeah.
would be,
Doesn't go how you want.
yeah, people usually don't want to talk about this, but I mean, it's necessary to do because surgery can be wrong.
Yeah.
It happens.
Yeah.
So
Complications.
yes, complications can happen, and talk about complications is more difficult than talking about just the good part and the success. Yeah. If you guys take a look on that picture, it's basically the way that we place a esophagus tube. It's not difficult. I mean, it's a kind of a mini surgery. As Massa told you guys, it takes 10 minutes, maybe even less than this. So it's not difficult. You need to use a hemostatic, so you can, through the mouth of the cat or the dog. Oh, we always try to put it on the left side because the esophagus in the cervical area is more to the left side than to the right side. So we're going to be closer to the esophagus when you use the left side of the patient.
And much less likely to cut something you probably shouldn't.
Yes. I was putting the left side when I cut the carotid, but I mean,
Yeah.
yeah. I mean, yes, but always try to put in the left side because it will be easier. And I mean, you just use the hemostatic to basically you insert the hemostatic through the mouth and you go into the cervical area, you know. And when you get there, you do a small incision, and through that small incision, we are going to place the tube. And the difficult part of this, I don't know if you guys can understand, but I mean, you're going to pull the tube until the mouth, make a turn, and then you make it go to the esophagus. It looks more difficult than it
Yeah,
really
yeah.
is.
It also really helps. I mean, this is why having them under anesthesia is best, because if you have them intubated, you're already protecting the airway, so it only has one hole to really go into.
This is the big question. People, when we show this picture, people say, "Hey, but how do you know that it's going to the esophagus, not to the trachea?" If you have a tube in the trachea, there is just
Much
one hole
less
to
likely.
go.
Yeah.
I mean, so there is no other
And
place.
especially, I mean, once you do that turn too, it can feel kind of weird, but you almost feel like a little pop when it
You
slides
do.
into place. If you're not feeling that, if you think it twisted on itself, you can always try and flush a little bit to see if it actually goes. And sometimes
Just a
you
little
can
bit, because if it is in the lungs,
yeah,
you
you
will
don't
not
want to do that.
put a lot of fluids inside the lungs.
Yeah.
Yeah.
But even if you do a little bit, sometimes that can help actually kind of push through. There is also, I think Mila makes what's called like an esophagostomy trocar, which is instead of using something like the Carmelts or the hemostats,
Yes.
you can use that trocar and actually attach it so that it can basically, you don't have to do that turn. So you place the tube into the esophagus already, and then use that to kind of go like make your
To the
incision
cauda.
on it,
Yeah.
and then you attach it outside of the mouth, pull it through the incision, and then it's already in the esophagus. So
Yes.
I've seen it. There's definitely YouTube videos for it as well. It's a little bit easier, so you don't have to do that kind of weird
The
turn
turn,
if you
yeah.
don't like it. But you know, it is definitely more expensive because I think it's like $200 to get something
Yeah.
like that. But
Yes.
you know,
I have never used this.
no,
I mean, yeah.
I've seen it before. I've seen people using it, but I've never actually used it myself. But honestly, if it's something that you can just use like Carmelts or you know any of the larger hemostats for, I think that works just as well.
Yeah. Yeah. Now, do you understand why we told that placing this in a big dog is difficult? Imagine a Great Dane.
Oh.
That's
The
a
distance
long
between
neck.
the mouth and the
Do they even
cervical
make something
area.
long enough for that?
With these patients, you can consider a nasogastric one, because as the nose is bigger,
Mm-hmm.
you would be able to give more food, or a gastrotomy tube.
Yeah, I was
Because
gonna
it's
say
closer and
straight
there's less
into
Yes.
straight
And
into the stomach or the jejunum if you need to do something
yes,
like that.
you can use a endoscope to place this kind of tube. But I mean, taking care of these tubes in the after surgery,
Pretty
I mean,
complicated.
yeah, it is a little bit complicated. So I mean, we try to. I mean, you are able to place a esophagus tube in a big dog. However, it will be more difficult than placing it in a cat. This will take 5 to 10 minutes. It's really easy to do. Yeah, and this is a picture after we had placed this tube. You can see that there are some small sutures just to hold this tube in the position, and this is the Foley tube. So this is Brazilian style. This is much cheaper than buying the proper esophagus tube.
And you do the kind of the purse string and then finger trap?
Actually, just one simple suture here, and then going up through the
Yeah,
through
like
the
the
tube.
finger trap?
Yeah, the
Okay.
finger trap.
Yeah,
Yes.
because I've seen
But no purse
string.
string. No.
Okay.
Do you do?
I was trained more to do a purse string,
Yeah.
but I guess it would make sense if you only did it just the one if you were able
Yeah,
to
just
get it
one and then you
secure
go up.
enough.
Yeah.
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 My always
Just in the way that is in this picture. And the other suture on the more dorsal part is just to hold a little bit more and avoid the
so it's
tube
not
to
flopping
yes.
around.
Yes. What I mean. So this is the aspect of it. Some other picture, we can use a bandage to protect it and keep it covered. And if you would take an X-ray after it, the things that usually you do in which space? This
We set like
the
the
9,
7
7 to 8, maybe.
Ish.
Yes. Because the tube needs to be inside the esophagus. If you take X-rays after you place it, you can see the tube here. However, keep in mind that you need to put in the esophagus, not in the stomach.
Okay.
So you need to take care of how much you are going to progress of the tube inside the esophagus.
You also don't want it right at that junction either, because between the esophagus and the stomach, that cardiac sphincter basically can cause a lot of irritation.
Yeah.
And it's basically like how we get heartburn. That's where that is. A lot of that acid builds up, can cause irritation, and it can lead to more issues with the sphincter later on. So we don't want to cause more problems by doing something like this. So just always take an X-ray after,
Yes,
confirm
to
the
double
placement.
check where it is. Yeah.
Then you can always pull it out if you need to, push it in further if you need to, anything like that.
Yeah.
But then afterwards, kind of depends on what you want to do. I don't know about you. I've done a little bit of bandaging, and then I've also done the kitty collar. If you've heard of that, where it's basically just like a padded collar that has a little slit already sewn into it to help kind of protect the area. But I've also just done vet wrap and cast padding, stuff like that.
These ones are very simple bandaging, just to protect it.
Mm-hmm. Just make sure it's not too tight, because that's definitely a problem that sometimes they can have.
Yeah.
You don't want to choke the cat or dog.
Yeah. It should be good to avoid it. They can eat, but they cannot breathe. So you still have a problem.
Yeah.
Yeah. Questions about the esophagus me too?
Hi, I was watching the phone.
Okay. Okay, so let's move forward. GDV.
Definitely, I think one of the more scary emergency procedures.
I agree with you.
I don't know as many regular vets that are very willing to do this. But I definitely feel like not one of my favorites personally, because it is scary. But
Usually they are difficult because they are big dogs,
older,
yeah.
usually more compromised. They're in shock. It's a lot more, concerning, especially for owners. They're already freaked out. There's a lot going
Expensive treatments that they need to approve.
You
$10,000,
say,
$12,000. Yeah.
your dog may or may not make it, but they only can do the surgery or euthanize. And that's really scary for a lot of owners. But I feel like if you can kind of explain a lot to them, the biggest thing is definitely being aware of things like this. Like if a dachshund comes in and they're like, oh my God, he has a distended belly, he's freaking out. What if it's GDV? Now, it's possible. I personally have never seen a smaller dog do it, but, more likely it'd be something like I think the top 3 breeds are like German Shepherd,
Great Dane,
and Weimaraner maybe? Or St. Bernard.
Okay. Yes, I don't know. I mean, because here in the United States you have other big dogs. In Brazil it's basically Great Danes, Labrador, Golden Retriever, and
no, I mean I've seen Weimaraners. I've actually even seen like
don't have
tall pit bulls. So definitely older dogs can be more predisposed. There's a lot of different things for what they say. Feeding 1 time a day, if they exercise right after eating, if they get really excited. But I mean,
there is a behavior aspect. There is a anatomic aspect. There are a lot of things that can make this happen or not. So it's not just one reason that a dog will have a DDV. It depends a lot.
Yeah, but it definitely, if an owner calls and say, hey, my lab is just kind of restless, panting, not able to sit down,
and
just
it happened suddenly. I mean, in the morning was everything okay, and after some hours something
just ate dinner and all of a sudden not acting right, things like that. Or if they're like, oh, they just keep gagging but they're not producing anything. These are definitely concerns. And if it's not something you're necessarily comfortable with doing, I would say definitely recommend sending them to an emergency or a 24/7 care, anywhere like that, just in case. I'd rather it be nothing than telling an owner, oh, they just might need to sleep it off or something like that. But if it's something you are capable of handling, have them come in as soon as possible. And especially once they get there, if it's something that you think is a concern, they see the distended abdomen, the really uncomfortable, panting, drooling dog, that's when you need to start stabilizing them appropriately, whether you decide to keep them or not.
That is the key in this case, the stabilization that you need to do.
Yeah, because it's not just about the surgery.
Yes.
A lot of it is preparing them, because
if you take the dog to the OR without preparing them, they are going to die.
Yeah.
Probably. They are going to die.
Yeah.
Because stabilization then.
They just
release
go
the
into
position.
shock because of
Yeah.
everything. I mean, the vessels are compromised. They're freaking out. You need to, really give fluids. You need to get blood work, give them pain meds, nausea medication, a lot of things like that, just to even prepare them to go in. And then that's not even including doing like gastric decompression as well.
Yes.
Especially if it's really big.
Yes, you just take the dog, for example, to the X-rays that are going to show some images after you do the stabilization. Otherwise, you're going to have a dyspneic patient doing an X-ray, and you're going to have a dead dog. Yeah, probably.
Yeah, I mean, if you just do one lateral, like don't try and flip them on their back or anything like that, they're not going to like it. They're going to flail around. Honestly, I had one dog who was a GDV patient who just came in panting a lot, and I was just trying to listen, and she ended up almost taking my finger off because she was just so in distress. And, if you go immediately towards trying to do something too much for them, it could put them into a decompensation.
Yeah.
So it does sound really scary, but as long as you have practice, you get your staff, especially to know what to do, get everything prepared. Sometimes I've seen people have like GDV bags, already have
With
catheters,
everything ready there inside,
trocars, stuff like that. That way it's easy just to pull out, have it available if you're concerned.
Yeah. So, for example, look at this dog. This was a Irish setter, I think.
Irish setter.
I think so. It was a dog that I cut in Brazil a lot of years ago. You see the size of the abdomen, the position that the dog was. This was after doing a gastrosynthesis to reduce the volume of the stomach. After the dog was on the surgical table, we were starting preparing the dog to cut him. Because what happens is that even when you do a gastrosynthesis, the gas will be inside the stomach again because it's still producing gas,
Yeah.
So if you take a long time to take to the surgery, probably you're going to need another gastrosynthesis to remove the amount of gas that you have inside.
Yeah.
So this is the classic case that you see. A big dog, the abdomen is big because of the gas. And what happens is that usually we have the spleen here on the left side of the stomach. And what happens is that the right part of the stomach will turn the cranial to the left part. So this is what happens with a GDV. And if you take a look, the spleen usually go to the other side. So usually when you open the abdomen, we find the spleen on the right side or on the left side, which also is a problem because a lot of patients, when you are doing the surgery, you need to also do a splenectomy because the spleen is necrotic because of the wrong position that it was placed for some hours. So the vessels are all compromised with that, okay? And the aumento, you can see that the aumento is over the stomach because of this rotation, So this is basically the movement that happens with the stomach. We have volume here on this TV.
Yes, but it's gonna be like echoing with everything.
Let's find out.
You need to turn.
No, we don't have.
You need to turn.
There we are doing.
Volume up.
What?
Your computer volume is down.
Yeah.
Well, it doesn't sound like ringing, so
I can listen to you in the.
don't listen to it.
So yes, basically this dog was with a GDV, and when we do this with our finger, what is the name of that? Percussion?
Yeah.
Finger to finger percussion. Is that it?
I think so.
Finger to finger. Because you can.
I just call it thumping. So.
Okay. Yes.
The not doctor.
You can hear. Can you call this tympanic sound?
Yeah.
We can hear tympanic sound.
Like
there.
a drum almost.
Yes, because you have air inside the stomach, a lot of air. So basically, this is what you can listen. And if you take X-rays, I like it with this when in Brazil we don't use this. We use the inverted C.
Oh.
Yes, because if you take a look at the stomach as it is rotated, you can see like a C to the opposite side. So in Brazil we call the inverted C or the opposite C, something like that.
Yeah.
But here in the United States you call
Smurf hat, double bubble. No, I have
Smurf
So
hats.
many- yeah.
I like it. Smurf hats.
The Smurfs. I don't know if you ever saw that show.
What?
It was like a cartoon show.
No, yes. I remember Smurfs, but I mean, in Brazil, we didn't call this type of image as Smurf hat,
okay.
you know. But I like it.
Yeah, it provides a little bit of extra joy to the patient.
Yes, yes. So this is the classic image that we see when you take X-rays, and this is the patients that we were preparing into the surgery, and we were the volume. Yes. I mean, you are not able to listen to it. However, what we do, this is a gastrosynthesis that we are preparing. So before taking to the surgery, we get a catheter placed in the stomach, and if you could hear, you'd hear the air going out the stomach, and the air is going out, and and if you do any kind of pressure in the abdomen to stimulate the air to go out anymore.
It also smells terrible.
Terrible,
Yes.
So,
because you're smelling inside the stomach. So.
Is there a preference on catheter gauge sizes? Like, would a larger catheter be more preferable?
The
compared
bigger
to-
you can use it, the
better.
The better.
But you want to keep it with the shorter catheters or the longer catheters?
I don't
Because I
think
know
it matters.
it doesn't
No, 50
matter.
matters because you're going to pass the skin, the muscle, the stomach.
so maybe longer.
The size is
Yeah.
enough.
Yeah.
Yeah.
Usually, I'll try the 2-inch.
Yeah.
I feel like sometimes I'll go for the 16 gauge first, just in case. I mean,
Yeah.
especially if you can
Feel
feel.
Yes.
Sometimes you can do like an ultrasound quick to make sure you're not about to stab the
Mhm.
spleen with the 16 gauge.
Yeah.
But anything like that. But I try and go for as large as possible because if you do like a 22 gauge, you're not going to get the air out.
Yes, but I mean, if you do the finger-to-finger percussion, can you call this?
Mhm.
If we do this and you listen to the tympanic sound, for sure the stomach is there.
Mm-hmm.
It's not the spleen there, because otherwise the sound would be different
Yeah.
when you do this
It
kind of
wouldn't be the
percussion.
air drum sound. It would be like a more meaty sound, right?
Yes, the solid sound,
Yeah.
So I mean, you can know if you are the stomach or not, but as Massa told you can get an ultrasound and
Yeah.
do
And
a
then just
test.
do it real quick.
Especially
Just
if
double
it's like a super deep chested dog.
Yeah.
You're worried about like the ribs being right there or something like
Yes. There are some patients that I used to place more than one catheter to be
Mhm.
faster.
Yeah.
that.
Yes.
Well, especially if
Put
there's
one,
a lot
another one.
if there's a lot of
Short
food
press.
and stuff, because sometimes it gets clogged and
Yeah.
it doesn't empty as fast
Yeah.
as you want to.
Yeah,
Yeah.
it happens. So this is before taking the patient to the surgery, even before taking the patient to the X-ray,
Mhm.
because remember you don't want to do X-ray with that big stomach. Otherwise, the patient can be dyspneic during the X-ray and they can die
Yeah.
during the X-ray. When you take the patient to the surgery, so these are usually when you do the celiotomy, as soon as you open the wall, you see the omentum all over the stomach, because remember the video that we showed you, when it goes to the other side, it brings the omentum together. So you can see that image. And on this other image, this is the worst problem that you can see in a patient like this. The stomach is necrotic.
Yeah.
This patient probably will die. Probably. It's really difficult to save this kind of patient. You need to do a gastrectomy. You need to remove part of the stomach because, I mean, it's dead. It's a dead tissue. So you cannot keep the patient with this. This usually happens when you have a patient with a DDV for a long time, 10 hours, 12 hours, 14 hours. There are some papers that they say that after 12 hours, the chance of survival is too low.
It's
Yeah.
too low.
Too low. I mean, 10% of the patients, 9% of the patients will survive. However, if you are able to cut this dog before 10 hours, 8 hours, the chances are bigger. The problem with this is that, imagine this dog at home. The GTV happens, I mean, midnight. The client is sleeping. They you see just in the morning, 7 a.m. in the morning. Until they are able to get a dog, put in the car, go to emergency. I mean, sometimes they arrive at the hospital with 10 hours of GTV. This is the main problem here. And we open the abdomen and we see this. We do the surgery, we can perform a gastrectomy, we will remove these parts. And if the patient is alive, we go and talk to the owners and tell them, hey, the chances are too low. too low. We can try, we can keep them hospitalized, or even you can consider in doing a euthanasia. I mean, I think it's an option. If you tell the owner that the case would be really difficult to survive. I mean,
Another thing you could do even before surgery, if you have blood gases available, lactate is one of the big things.
yes,
They've done a lot of papers where the higher the lactate is, the worse the prognosis is.
Yeah.
So if
There
you
is
have
a
a
direct
lactate of
correlation.
like 12, then that's definitely a sign that there's probably already necrosis. The patient's already in a worse state. And even if you try, it's highly likely they're going to have complications even if they make it through surgery. So a lot of times, especially if I get that, anything similar to that, I let owners know right away, this is an extremely guarded prognosis. You know, I can try, but if there's any signs of any problems, it's highly likely that they may not do well. And sometimes these patients don't even make it to surgery because they're already compromised.
Yes. And sometimes you have a good surgery, the patient is doing well, however, they die after 2 or 3 days.
Mm-hmm.
Yes, this can happen because of all the consequence that happen to that organism because of the DDV.
There's a lot of inflammation. There's a lot of problems with the body. Sometimes you have to monitor for arrhythmias, and
Yes,
especially if you have to remove the spleen because all of that blood flow's been cut off. It's not only just the stomach. I mean, this is going to the entire rest of the body.
Yeah.
And shock itself can do so much to the rest of the body.
yeah. So this is a nice video. Remember the video that you saw of the movements that the stomach does going to the other side of the abdomen? This is during the surgery, we are going to put the stomach again in the correct position. So there is blood because when the stomach rotates, there are some vessels that they cause a rupture. So you can have any kind of free blood, as you can see. So we are draining it. I am this part of the video. So I'm positioning my hands in the stomach, trying to locate the parts that was to the wrong side, and I get it and I give it back to the place. Did you see the movement coming back?
Yeah, I mean, the way I've always been able to do it if I can is try and reach basically to the sphincter if possible and almost feel where it is. And if there is a lot of rotation, then you kind of have to figure it out. I also try and find the pylorus if possible. And
Yes.
switch it like
Yes,
this.
basically do this. Yeah.
And if
Yes.
you can, if your technician is able to do this, you know, if the patient's stable enough, they can try and pass a gastric tube as you're doing it. Because as soon as you can get it, if you can feel that tube go in,
It's a good reference to have, and
and it's a lot easier to decompress the stomach while you're doing it, because when it's so gigantic and so big, you can even do a decompression with a trocar while you're in there, but it's so much easier if they can pass that tube, get all of that stuff, food, bile, air, and then flip it like that.
Yeah. After doing this with the stomach, there is something important to do with this patient, because if this happens one time, it can happen again. So every patient can present another DDV. So to avoid this, we do a gastropexy. So basically, we suture the wall of the stomach with the wall of the abdomen in the right side. Remember, that is the right side that rotates to the left side. So there is no reason to suture the left side. But yes, we need to suture the right side. Okay. So on that picture, you can see the incision. Here we have the abdomen wall. Here we have the stomach. We do a seromuscular incision, so we don't open all the layers of the stomach. We just open the serosa and the muscular, and go in the muscle, in the abdomen wall, and we do a simple continuous suture. One line and then another line. So here the stomach, the liver is here, and the stomach is attached to the abdomen wall. So with this, you reduce the chance of the DDV happening again from 8% to 5%, according to the papers. So I mean, this will not happen anymore. And some papers, they tell us to do a prophylactic gastropexy if you are opening the abdomen of a dog that can have DDV in the future. So Great Dane, when you're going to spay, Labrador, if you have the abdomen open for antibiotic surgeries, go there and do a gastropexy. because of that you're going to avoid a GDV in the future. There are some papers that they talk about lap spay. So when we do it with the video laparoscopy, and you can go there in the stomach, do a small suture there just to avoid the GDV to happen. So I mean, what's your opinion about that? Do you do prophylactic gastropexy?
Basically, any patient, if they come in, especially for a foreign body surgery and it's a large dog, sometimes I get super anxious, even if it's like a cattle dog or something. Like, you're kind of deep chested enough that just in case, I'm already here.
Yes.
Everything's going well. The patient's stable. I mean, obviously, if the patient is not stable under surgery, then you don't have enough time to do it.
Yes.
That's different.
Yes, because it will take you 10 to 15 minutes
Yeah.
to do this. So I mean, yes.
And if you have someone to help you, sometimes I'll have my technicians hold the body wall up. That way I can actually see where my incision is, see where the stomach is. It's a lot easier. But anytime, I mean, labs, Great Danes, Weimariters, any sort of, even I've seen Basset Hounds, because they're deep chested, even if they're small, they can still have these problems. So it's always better to just do it spays anytime.
Yeah.
I'd be like, cystotomy, I don't even care. Just go in.
Just tack it down.
Yes.
It's always better to tell the owners, you know, for me, especially since I'm already there and we're already doing emergency surgery, I'll kind of just tell them after. But especially if you're doing a spay, I would just say, hey, you know, these dogs are very prone to GDV. This is something that can happen a lot later in life. Is this something you'd be okay with me doing?
Yeah.
And I mean, whether it's up to you if you want to do like an additional charge, additional anesthesia charge, or anything like that, just let them know, like, it's a lot better for you, because even if you're spending an extra couple hundred now, it's better than $6,000 or $7,000 later for them to may or may not do well.
Yeah, I agree with you. And I mean, when you talk about this questions about the GDV?
I don't have any questions. I just wanted to say someone commented, Kelpar said, outstanding content, so many options. Thank you for showcasing all the amazing techniques you use to save the pets.
Oh.
That was one comment that we used.
Nice.
So you guys were
So mom love.
We love her.
Okay, sorry, mom.
Thanks, Mom.
Hello, Massa's mom. So when we talk about DDV, we talked about splenectomy, because we can do a splenectomy because of a DDV. But also there are some other reasons for us to perform a splenectomy. And there is something that we can see in the papers. So remember that the spleen will be in the left side of the abdomen. And there are some specific vessels that they go to, deliver blood to the spleen. We have the short gastric arteries. We have the left gastroepiploic artery, the splenic, and there are the main splenic branch, and also the omental branch. There are some papers that they say that you are able to do a splenectomy just with these 4 sutures. If you go to this specific location and do sutures there, you're going to be able to remove all the spleen, because all the other vessels, they come from these main vessels. However, we were talking about this 2 days ago. However, you need to know exactly where to place the suture. Otherwise, you can cause necrosis in the stomach or in the pancreas, because some of these vessels, they go also to the stomach and to the pancreas. You need to know exactly where to place this suture.
And sometimes it's not, it's not too bad, especially in like thinner patients where there's not a lot of like fat in the area, especially between the ligaments of the stomach and the spleen. It's a lot easier to see some of those vessels. And if you can, clamp them off pretty easily, if you can see where it says 1, 2, 3, and 4, those are kind of the main parts that they were talking about. But in cases where it's a lot of stuff blocking your way, or especially if it's like a bleeding spleen or a ruptured spleen and there's a lot going on, it's a lot harder to...
You're not able to see this.
Yeah.
Yes.
To just stop and say, all right, let me just debride all of this tissue away so I can find these small vessels.
Yeah. So the other way to do this is just going really close to the spleen and doing a lot of small sutures there to take more time. However, it's safer in some cases than trying to do these specific sutures. You know what I mean? It's an option. In this picture, you can see, for example, some masses, some tumors in the spleen. This was the reason to performing this surgery. This is yours, yeah.
Yeah, it hadn't ruptured yet. It was just a very large mass. The owner actually brought it in for a distended abdomen. We were concerned for GDV. Then we took x-rays and we saw this, which was extremely large. Actually weighed, I think it was at least 10 pounds.
I think it was
No,
closer to 12.
Oh, yeah.
Over 12, yeah.
12 pounds.
Oh yeah.
So you can see kind of the actual head of the spleen over here, and then this was actually the tail. And we ended up having to make an extremely large incision and then also kind of make a pericostal incision in order to open up the skin because I just couldn't even get my hands enough.
Yeah.
And for me personally, I absolutely love the ligature. So if it's something that you can invest
I
in,
love ligature.
it's so much better.
Yeah.
In this case, I actually couldn't even get the ligature around some of the vessels because it was so large. So a lot of it was a combination of me clamping off, making some ligatures, and then if I could get to an area, using the ligature. But the ligature itself is like a little scissor gun, and you can use it, cauterize it, and then it will cut it itself, and then you can kind of get everything off. But it was definitely this one, it hadn't ruptured, which was good, but there's other cases where they do rupture and then it becomes into a whole emergency situation.
Yeah, you need to be fast.
Mhm.
So if you have a ligature, for sure you're going to be faster than if you do not have a ligature.
Yeah.
Or any kind of vessel sealer device. But I mean,
it turns into like a 15-minute procedure, whereas finding every single vessel is so much longer, especially when you're already adrenaline's pumping, you're trying to find the actual bleeding part.
Yeah. This spleen was with a patient with a GDV, and look the necrosis that we have in this spleen. So we need to remove this spleen. So this one had no masses, no tumor, but we did the splenectomy when we were correcting the GDV. Yeah. So putting the stomach in the position again, doing the gastropexy, and removing the spleen of this patient.
I've also seen splenic torsions. It's not extremely common, but we had one patient where everything else was fine, but she'd gone to her vet earlier that day, said it was a little bit weird. She monitored when she came to me. The spleen, I could visibly see it, and you could palpate it. And then when we took it out, the whole thing was just twisted over.
Yeah. Some spleens will rupture. So usually when we take this patient to the surgery, as soon as we open the wall, we can see a lot of blood. And when we start looking for where the bleeding is, we can find it from the spleen. So we go direct to the left side, put our hands there, and try to pull the spleen. Some big tumors, big masses. And as Massa told you guys, you need to be fast on these situations, yeah? And what makes the surgery much faster than doing sutures is using the ligature. Just for you guys to know, the ligature is the name of a specific vessel sealer device. You have other brands of a vessel sealer device. The one that you have here in the hospital is not a ligature, actually. No. We call it ligature, but it's Vetoviation, I think, the brands.
What is the actual tool called?
It's a vessel sealer device. Vessel sealer device. So there are a lot of brands and types of vessel sealer devices. Ligature is is the most famous one. Mm-hmm. It is from Covidian, the brand that's responsible for producing ligature. This is a ligature. This is a video of mine from Brazil. And I used to say that my life was, I was a surgeon before ligature, and another surgeon after ligature. Yeah, it's changed my life as a surgeon. Because what you do is this. Instead of doing a suture, and that's it. You just press a button, wait 3 or 4 seconds, then you open it. And
enjoy the smell.
Enjoy the smell. So Ligature is able to do this in vessels up to 7 millimeters of diameter. So really big vessels you can just seal the ligature. I mean, it is an amazing equipment. You do the whole surgery with no suture material. It's much faster from skin to skin. I mean, from the incision from the incision to the last suture that make the skin with everything closed. It will take 15 minutes, less than 20 minutes in most parts of the surgeries. If you had to suture everything, probably would take 40 minutes, 50 minutes, an hour. So I mean, it's a huge difference. The problem of the ligature, of course, is the cost is expensive. So having a ligature is not that easy. But I mean, basically, you keep doing this in all the vessels, and that's it. You are done.
You can also use it. I've used it for pyometras, C-sections where I'm removing the
Yeah.
uterus bays,
You can use this from
neuters.
yes. I mean, it's a fantastic equipment. It helps a lot. I mean, I would never do a surgery anymore without a ligature. Yeah, I would never do this. Yes. After you get used to this, yes, it's impossible not to have a ligature anymore. It's impossible. It's impossible. I mean, does not make sense doing a suture.
Honestly.
Yes, without a ligature. Okay, guys. So thank you, everybody. Thank you, Dr. Massa, for being here today. If you have any kind of question, just let us know. We'll be more than happy to answer you. And buy a ligature if you don't have one. This is the final.